right, I would like to welcome everyone to this virtual briefing offered by the National Home Infusion Association. Today, we'll discuss why home infusion is an important site of care, particularly for seniors and patients with underlying health conditions during the COVID-19 pandemic. My name is Connie Sullivan, and I'm the President and CEO of the National Home Infusion Association, and I will be the moderator for today's discussion. It is my pleasure to introduce our distinguished panel of experts who will share their perspectives on home infusion services. We have Dr. Ryan Thompson, who is the Medical Director of Care Continuum and Complex Care at Massachusetts General Hospital. Kathleen Sheehan is the Vice President of Public Policy for the ALS Association. Logan Davis is a home infusion provider and Director of Franchise Development from Vital Care, Inc. He is also the Chair of the NHIA Board of Directors. And Felicia Schatz, who is an expert in home infusion nursing and serves as a Presidential Advisor for the Home Infusion Nurses Society. I want to thank our panel for participating on today's call. And for those listening in, please note that your line will be muted until we reach the end of the panel discussion. We will open the lines for a Q&A at the end of the presentation, or you may use the question feature to submit a question at any time during the session. Before we turn it over to the panel, I would like to set the stage for our discussion by providing a bit of background on home infusion services, which are used to treat patients who need IV medications but do not necessarily require hospitalization or around-the-clock care. Common conditions where home infusion is highly utilized include treatment of serious infections, diseases of the GI tract, immune deficiencies, cancer, and chronic neurological diseases such as ALS. Home infusion providers today treat successfully over 3 million patients annually. And one of the key advantages of being treated at home is that it keeps vulnerable patients away from other threats of infectious disease. And finally, transitioning patients to home relieves capacity for hospitals who need to focus on treating COVID-19 patients. While home infusion is readily accessible for patients with commercial insurance, for Medicare beneficiaries, coverage of home infusion is limited to approximately 30 drugs that require the use of an external infusion pump for administration. Home infusion coverage for these drugs has existed under the Part B, as in boy, DME POS benefit for several decades. And recently, this benefit has been expanded to cover professional services associated with providing these therapies. This is in contrast to over 100 home infusion drugs that are available under the Medicare Part D benefit, where there is no coverage for the supplies or services necessary to safely administer the drug in the home. NHIA estimates that approximately between 17 and 24 million Medicare beneficiaries today do not have access to home infusion drugs due to this gap in coverage. Instead, Medicare beneficiaries typically receive infusions in higher cost settings, such as hospitals, physician offices, or nursing homes, which can also create a burden to patients and families from having to travel, sometimes great distances, to receive treatments. It also places patients at risk of exposure to secondary infections or causes patients to endure lengthy separation from family members. The graph on the screen is an excellent representation of the difference between how commercial plans and Medicare leverage alternative sites of care, such as the home, for home infusion therapies. With that introduction, I'd like to go ahead and turn it over to Dr. Thompson. Dr. Thompson, feel free to begin.
Hi, thank you very much. This is Ryan Thompson up in Boston. I work in the care continuum space for both Mass General, and I've also been leading our care continuum efforts for Partners Healthcare as part of the coronavirus response. And I'm really grateful that you're all taking time to participate on a topic that we feel is very important to the safety of our patient care delivery. Really from the first phase of the COVID response, before things had really ramped up here in Massachusetts and we got hit pretty hard, as you may know, we were immediately mindful of opportunities that we would have to try to keep our patients at home, in particular our elderly patients and our clinically vulnerable patients who are immunosuppressed or who have other reasons to come into the hospital normally for infusion. I think because of the environment of the hospital, really the patients were wondering what could be done to try to keep them at home. We've had long-standing collaborations with several home infusion companies and pulled together some conversations about this. I think one of the challenges is we started to work through our approach to this is that there are some of these payment barriers in place. And I think both short-term and long-term is coronavirus hopefully will die down, but it's not going to go away. I think we have a lot of interest clinically in thinking about optimal care for patients, in finding additional ways to deliver these needed infusions at home. Not all care can happen at home. There's reasons why hospitals and clinics exist, but I think as we think about the future state of healthcare coming out of this pandemic, there needs to be more dialogue around additional care capacity in the home, whether it's programs like Hospital at Home, which we run here out of Partners Healthcare, whether it's home infusion. There's a lot of advanced strategies that can be done at home if we have the right supports, delivery options, and payment mechanisms in place. I'm going to just offer, because I really think it's stories that really drive our thinking about this, because we don't have a lot of data yet. I'm just going to offer two brief anecdotes from my own clinical experience in the past month here. The first is going to be a patient. I was the attending physician on our home hospital program 2 weeks ago, and we've tried to focus that program on frail elders who are frankly terrified of coming into the hospital in the current environment. I took care of a patient who was 94 years old, who would have, for all intents and purposes, been in the hospital. She had an acute leg infection, cellulitis, that needed IV antibiotics. She had failed 3 courses of oral antibiotics, and it was very clear that she needed IV therapy. We happen to have a home hospital program, but there's no coverage for the IV vancomycin and antibiotic that she needed at home. So either we pay for that out of the hospital, which we're doing in this case, or the patient pays for it. Regardless, it's not a scalable model to do more of this sort of care for frail elders who need it in the future. Fortunately, we've been able to treat her at home. She's better, and I think it's a nice success story, but it's not one that could occur with any scale in the current environment in terms of coverage. And just one other brief anecdote is actually from a very close personal friend of mine for the last 10 or 12 years, who was diagnosed with Lou Gehrig's disease, or ALS, about 3 years ago. And it's been a really tough journey. This is also a family that has been involved in COVID, and the wife of my friend is a nurse. They also have a handicapped son, and they've really gone through unique challenges. It's been challenging, though, because my friend, he has an immune variant of ALS, and actually normally comes into our infusion clinic for IV intravenous immunoglobulin once a week to treat his condition. And in his immunosuppressed state, the fact that he has had to come in every week, I think it's been very hard. He's been frightened every time he comes in because of the risk of exposure. I would do anything to try to get coverage and support for him to get this therapy at home. It would be safer for him. It would be better for him. The logistics of coming in and parking and everything has been very hard for this family. And I think if we could find enablers and mechanisms to allow this sort of delivery to occur at home, I think it's a win-win-win for everybody. It's lower cost, it's better for the patient, and it frees up capacity in the hospital. And so I'll stop there and look forward to taking questions and hearing from the other presenters.
Great. Thank you so much, Dr. Thompson. Kathleen.
Yes, thank you so much. Dr. Thompson did a great, provided a great example of a person living with ALS, and Mass General certainly treats a lot of people living with ALS. I just want to tell you a tiny bit more about the disease, and then I'll tell you how important home infusion is. So Lou Gehrig's disease, or ALS, is a neurodegenerative disease that affects the nerve cells in the brain and the spinal cord. It can start in any location of the body. It can start in your feet, it can start in your arm, so it's very variable. It is a spontaneous disease, which means that anyone can get it, and it happens to people at all different ages. There's a very small percentage of people who have a genetic marker, but for most people, it's a devastating surprise. It takes a very long time to diagnose the disease because it's a process of elimination. And as you can see from the picture in front of you, it really debilitates patients who are not able to move and who really want to have the best quality of life for as long as they can have it. The average life expectancy for someone with ALS is 3 to 5 years. I think that what's most important, and Dr. Thompson mentioned this, is the caregivers. For many of the people that we serve, and we serve about 20,000 people through our clinics, their families are their caregivers. And we've heard a lot in the news recently about the concerns of caregivers with regard to this. So the dynamics of getting a complex wheelchair, getting someone into the wheelchair and to the hospital, and all the procedures that are involved in a hospital visit are very, very challenging. And I hope some of you have had some experience with people in this situation, so you can really get what it means for them. There is no treatment and no cure for the disease. There is a medication that was approved in 2017 that does provide some symptom relief. We find that some of our people living with ALS who are taking this medication feel that it makes a big difference in their life. As I was talking to our folks about this issue of home infusion, some of them said to me, well, we don't have any problems with home infusion. And I said, well, what's your coverage? And they said, well, we have commercial in coverage, and someone comes to the house and takes care of us and gives us the drug, and there's no problem. And then I talked with another person, and they said, I just can't get this. I'm very, very frustrated in terms of being able to get the drug I need. As I mentioned, Radicava was approved in 2017. It's a home infusion drug that it must be administered in 28-day cycles. And so, as you can imagine, that requires a lot of time on the home infusion piece of equipment. We really feel strongly that it's important that everyone living with ALS have access to home infusion. There should be fairness. There should be a level playing field. I think this is really a glitch in terms of how the Medicare program covers this. I would agree with Dr. Thompson and the other presenters that this would be a much more suitable, low-cost alternative that would really protect people living with ALS who are already living very challenging lives and who want to maintain that quality of life. So I really urge everyone on the phone call today to advocate with Congress that we find a solution. It's urgent. As I noted, there isn't really cure and aid treatments for ALS. We're hopeful that there will be some breakthroughs in the near future. But right now, home infusion is really critically important, especially given the COVID crisis and the vulnerability of these patients. I'm going to stop there and look forward to listening to the other panelists and answering questions at the end. Thank you.
Thank you so much, Kathleen. I'll turn it over to Logan next.
Great. Thank you, Connie, and thanks, Kathleen and Ryan, and appreciate everyone being here today. I really want to talk about the perspective of a home infusion provider and kind of give some background, and I'll try to walk through my comments here. Home infusion providers have been providing infusion therapies to patients in their homes for over 40 years now. It's very established therapy and course of practice in the practice of medicine and pharmacy and nursing to take care of patients in their homes with infusion therapies. Typically, these home infusion providers are licensed as pharmacies, and they have special certifications around sterile compounding, around the service level that they provide, that sort of thing. But that's a standard of care in our home infusion industry. These businesses, these providers employ pharmacists, nurses, technicians, and care coordinators, and sometimes other staff to pull off this model of care of infusion in the home. From my perspective, with Vital Care, our national network of home infusion providers are really home infusion providers that are primarily in rural and underserved areas throughout the country that are setting up these teams to provide infusion care in the home that otherwise wouldn't be possible without that care coordination. One important point is, all these home infusion pharmacies, home infusion entities, are set up to ensure safe compounding and preparation of infusion drugs, and that's such an important topic from a patient safety perspective. Another important point is the coordination of care that happens in home infusion and with home infusion providers. We think about coordination of care as kind of like an air traffic control center. The home infusion provider is air traffic control between the physician, home health agencies, discharging facilities, referring clinics, anyone involved with that patient's care in the home. The home infusion provider sits in the middle and ensures that care is coordinated and that it happens safely and effectively in the home. And that's really the value proposition of home infusion providers. And it's a value proposition that private insurers and frankly most every payer in the United States has taken home infusion providers up on and has paid a service, a per day fee for the home infusion service. So this is per day that a patient receives a therapy, regardless of if it's administered by a nurse in the home or whether it's self-administered under the care and supervision of the home infusion provider. And so that's really, as others have mentioned and as we'll talk about, that's really where Medicare has gaps. They do not have a home infusion services program that covers the vast majority of home infusion drugs, which happen to live in the Medicare Part D as in dog benefit. And as providers, we want to solve those problems. The story that Ryan told in the beginning is heartbreaking because, we know that from a scalability perspective, those inconsistencies in access are really hurting patients who honestly need the access to home infusion therapy the most as we think about our current environment. One final comment I'll make just about Medicare. We took note of the interim final rule that Medicare published a few weeks ago, and they made a reference to infusion therapy in that rule, and we appreciated the gesture that we think was made there. But from a provider perspective, we really found that the rule fell short from actually accomplishing access to home infusion for patients throughout the country, especially those impacted by the COVID crisis. There's several reasons that I won't get into the weeds on, but it's not been a practical, actionable solution. And being a provider that talks to providers all across the country every day, I've still not spoken to a home infusion provider or physicians, frankly, that have been able to set up home infusion under the concept suggested in the interim final rule. And so we were disappointed that Medicare didn't go further there, and we're hopeful that between Medicare and Congress, these patients can find ways to get better access to home infusion therapies that they need.
Great, thank you for that insight, Logan. And finally, Felicia.
Hi, I want to thank NHIA for asking me to speak, and also to all of you who are listening to this presentation. As Logan said, home infusion providers have been safely and effectively administering IV medications in patients' homes for over 40 years. I can personally speak to that since I have been one of those nurses who's been providing that care for 36 of those 40 years. I'm currently the general manager of a home infusion pharmacy. My nursing staff consists of highly skilled registered nurses who are trained in the specialty of infusion, and they're acutely aware of which medications are safe to administer at home and which are not. Many of my nurses and infusion nurses throughout the country are also board certified in infusion nursing by the Infusion Nurses Society. The nurses are trained to safely and effectively administer high-tech therapies. They can place IV catheters. They use their critical thinking skills to manage any issues should they arise. These nurses are also educators when they go into a patient's home. They're teaching the patient or their caregiver to self-administer their medication. They encourage patient independence, and they continue training patients until either the patient or the caregiver feels comfortable doing their own care. They do return to manage the IV catheter and to collect labs in the patient's home. In the home, the patient has a primary nurse, so that limits their exposure to just one person, maybe two if that nurse, is not able to make the visit, but it greatly limits how many nurses they're exposed to, different than what it would be in the hospital. The nurses are provided with personal protective equipment like masks and gloves. and gowns, and this equipment protects both the nurse and the patient. Our patient population is primarily the at-risk group for COVID-19. They're older patients, maybe with kidney or heart disease. They also may be immune deficient. So we'd love to be able to keep them at home, and they want to stay home. They're afraid of going to the hospital. They're afraid of going to a skilled nursing facility. They want to be where it's safe and they're not exposed to a lot of people.
Thank you so much, Felicia. Thank you to all of our panelists for sharing your insights on the important role home infusion plays for patients you see in your areas of practice. And I just want to summarize by saying that despite the pressing need for home infusion, current CMS policy has not provided sufficient patient access, as you heard from, particularly from Logan. And as a result, over 180 House members and 30 senators joined letters to HHS requesting the agency expand access to home infusion services. We also have leading health systems that have collaborated in requesting that CMS issue a blanket waiver, expanding home infusion access to drugs covered by the Medicare Part D program. And you can see on the slide here that over 160 stakeholders support concept legislation that would cover home infusion services, supplies, and equipment for the duration of the COVID-19 pandemic. And on the slide are just some of the major organizations who have signed on to that approach. So with that, this concludes our portion of the presentation, and we would be happy to take some questions from the audience. Feel free to unmute your line if you would like to ask a question, or you can also use the question feature. On the next slide, I'll also point out that while we wait for some questions to come in, we do have some folks who are willing to answer questions after the webinar ends today. If you have a need to follow up with anyone regarding information around the policy proposals for home infusion access expansion for Medicare beneficiaries. So with that, I think Shay McCarthy is actually going to monitor the questions that are coming in via the question function. Otherwise, would anyone else like to unmute their line and ask a question?
Hello, Connie. I know Shay is monitoring the questions. We don't have any at this time. If someone would like to ask a question of the panel, please go ahead in the attendee section and raise your hand. This will allow me to unmute you so that you can ask your question, or you can put your question in the question tab also in the navigation pane.
Thank you. And while we're waiting, I did have a question that came in prior to the call, so I'll direct this one to Logan, if you don't mind. Logan, could you just describe which payers do cover home infusion services today?
Sure, Connie, happy to speak to that. And, I'll speak in broad terms, just, related to sensitivities as payers contract and do their own thing. But as I see across the country, working with Blue Cross plans, United Healthcare, Cigna, Aetna, Humana, the VA, TRICARE, most state Medicaid plans. Really, we see all of these plans, both large and small, having some sort of coverage for home infusion, and that coverage most often looks the way I described, with a per day, per infusion day payment that's set up to cover the home infusion services, supplies, and equipment. So it's like a one bundled per day payment, and that comes in addition to the drug and any nursing that the home infusion provider might be providing out in the field.
Great, thank you. I don't know if any other final questions have come in.
This is Shay. Connie, one question that I've heard consistently on this issue is the fact that most physician-administered drugs are covered under Medicare Part B, but in the opening of the call, you pointed out that it's drugs that are covered under Medicare Part D for which there are no professional services payments that would be required to actually administer those medications in the home. I'm wondering if, I don't know if this is appropriate for Logan or anyone else on the panel, to provide some clarity over the coverage of drugs, because I think that a lot of us have this understanding that physician-administered drugs are inherently Medicare Part B drugs, and I think I've gathered that that's not necessarily the case.
Yeah, Shay, it's Logan. I'll take a first swing at that, and hope others will join in as well. It's an important question, and you're right, one we get asked a lot. As I think about drugs and where they're covered, how they're covered, I think it's important that we look at coverage in the Medicare program based on the site of care and not on the drug itself. So, for example, a number of drugs, almost all infusion drugs, honestly, can be covered under Medicare Part D, as in dog, if they're administered in the home. If they're administered in a physician office or a hospital outpatient department, then they're going to be covered under Part B, as in boy, incident to that practitioner's services. But as I mentioned, if that drug product is dispensed and administered in a patient's home, it's covered under Part D. And that's really where the big gap is today. So in the Part B, as in boy side of things, a physician office, a clinic, a hospital outpatient department is able to bill, and they're already enrolled with the parts of the Medicare Part B, as in boy program, that they ordinarily bill for products and services to. So they bill for the drug and the associated infusion services on the Part B side. Where the gap comes in is home infusion providers are ordinarily all contracted with Medicare Part D, as in dog plans, for billing on the drug. But there's, ordinarily these providers are not contracted with the same portion of Part B that clinics and hospital outpatient departments are. They're contracted with the portion of the Part B program that covers durable medical equipment. And so we see a path for payment of home infusion services under Part B, as in boy, while the drug is dispensed and billed to Medicare Part D, as in dog, as providers are already set up to do. We think that's the most efficient and easy to stand up program, and that's so important during this great time of need that we're in. There's not really time to go through a complex new enrollment process to get this going. We need something that can happen now for these patients.
Thank you so much, Logan. And I do want to be respectful of everyone's time. And I want to also just thank Dr. Thompson and Kathleen, Logan and Felicia for sharing your perspectives. Particularly, I think the examples that Dr. Thompson and Kathleen shared around patients who benefit from these services were very insightful and compelling. So thank you, everyone, again, for participating in today's discussion. And feel free again to reach out to us if you have follow-up questions. Thank you all so much. Have a great day.